This microlecture will address enhancing observation skills as they relate to counseling in speech and language pathology. Observational skills are not new to us. We hone these skills through long practice. Knowing that a vast majority of communication is nonverbal, nearly 90% in some estimates, observing our patients' nonverbal signals and their words will give us clues about how to proceed if a counseling moment or a counseling response is needed, and can help us craft that moment or response. Nonverbal cues such as facial expressions, body language, and autonomic responses and their verbal behavior can often provide critical insights into a client's emotional state, engagement level, and comfort within the therapeutic environment. It can be easy to be so focused on our clinical or academic objective that we may miss some or all of the patient's responses to our presence or our intervention attempts. Nonverbal cues can give us a wealth of information. For example, while eye contact can be correlated with empathy and connection, breaking eye contact or shifts in body posture can signal that a patient may disagree, may be uncomfortable, or could just be looking out the doorway if there was movement out there. Looking down can sometimes signal that a patient has had a moment of recognition of the truth or accuracy of something you've said, but it could easily also be a desire to disengage. Facial expressions provide a window into the client's potential mental state or thoughts, as we're all aware, yet we tend to make assumptions based on our own cultural backgrounds. Nonverbal cues like eye contact, body position or movement, and facial expressions are not universal across cultures. Taking a bit of time to discover cultural differences can be helpful to interpret these nonverbal signals. Autonomic responses, on the other hand, tend to be somewhat more universal. Tune in to any shifts in autonomic response, such as increased respiratory rate, pupil dilation or contraction, tensing of the muscles, skin flushing, or a sense of sudden disengagement. Have you ever heard a popular song that is upbeat and catchy, and then you realize that the lyrics are either heartbreakingly sad or rage-filled? As you observe nonverbal signals in your patient, pay close attention to whether these nonverbal clues align with their verbal message. These can be important clues to the inner life of your client. Any of these are great openers for a counseling moment where you can reference what you've observed and then ask a question. Mirroring or reflecting a client's nonverbal behavior can profoundly impact rapport and trust. And this often happens organically when two communicative partners are in sync with one another. This can include body posture, leaning in or sitting back, crossed or uncrossed legs or arms, facial expression, and eye contact. You can also observe when this is not the case. It could be a signal of disagreement, disengagement, or other negative response. Co-regulation is a slightly different but related term that refers to a gentle push-pull between the patient and clinician. For example, studies show that when a patient becomes agitated and their speech becomes rapid, the clinician's speech automatically tends to slow. And if a patient shows a slowed or limited response, the clinician's speech rate and affect tends to increase. We can use each of these without either overdoing or intentionally parroting a patient's nonverbal communication. As we listen to our patients, we may find that specific words are emphasized and come up over and over. These could be signposts pointing to what is important to the patient or give clues about their outlook or worldview. Using their words can help build trust and rapport. If those words are negative, we can also help draw their attention to this with our listening, attending, and empathy microskill. In further microlectures, we will discuss how to help patients shift their perspectives. Verbal behavior can indicate how a person thinks and help us choose our language and approach to counseling communication. Concrete communicators will favor giving examples and situations, for instance, telling a detailed story, where an abstract communicator may be more analytical and reflective of their experiences. It'll be helpful to communicate in a similar manner during counseling moments. It's also helpful to observe whether a patient's communication indicates a sense of agency or self-efficacy, or whether their comments seem focused on others having power over them. For example, a patient may say, "My wife won't let me talk without butting in," versus, "I'd like to be able to speak for myself." Or, are their I statements self-empowering or self-denigrating or defeating, such as the difference between "I'm getting better at this" versus "I'll never be able to do this." Since we are all expert observers of our patients, I'm hoping this microlecture added a slightly different lens for this already well-developed skill set, one that will help us be even more attuned to the emotional needs of our patients as they navigate adjustment to their communication or swallowing issues and seek to advocate for themselves. Please explore this type of observation this week and reflect on what it adds to your clinical or academic work.